Hello, everyone, and thank you for attending today's webinar entitled C. diff Perspectives, Utilizing On-Demand Testing for Protocol-Driven Infection Prevention. My name is Zach Crowther, and I'm a marketing manager with Cepheid. Before we begin, we wanted to cover a few housekeeping items. At the bottom of your audience console are multiple application widgets you can use. If you have any questions for the speaker or host during the webcast, you can click on the Q&A widget and submit your question. We will try to answer your question during the webcast, but if a longer answer is needed or we run out of time, it will be answered later via email. We do capture all questions. A copy of today's slide deck is available in the resource list widget that looks like a green folder at the bottom of your screen. You can expand the slides by clicking on the maximize icon on the top right corner of the slide area or by dragging the bottom right corner of the slide area. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. An on-demand version of the webcast will be available approximately 1 day after the webcast and can be accessed using the same audience link that was sent to you earlier. I'd also encourage everyone to please fill out the survey, also located at the bottom of the console at the end of the webinar, to share your feedback. Today's presentation is the first in a 3-part series examining different perspectives on C. diff. Please note, while the next 2 webinars in the series will be 60-minute presentations offering PACE credit, this webinar will be 30 minutes and therefore is not eligible for PACE credit. Whether for the PACE credit or simply for the information, we do hope that everyone will join us next month and again in March for these next 2 presentations in the series. If you've registered for this webinar, you will automatically receive invitations for those events as well. Okay, that concludes the housekeeping announcements, so I'd like to move on and introduce today's speaker. We are very pleased to be joined today by Trish Gould from CHI St. Vincent in Hot Springs, Arkansas. Trish is the registered nurse with 13 years of infectious disease experience. She is a past president of the Arkansas APIC chapter and received an award from the Arkansas Foundation for Medical Care in 2014 for her work with C. difficile reduction. Trish's talk today highlights the work she and her team have done to reduce C. diff rates in their institution, utilizing on-demand testing, protocolized reporting, and physician education to achieve results. Thank you for joining us today, Trish, and with that, I'll hand it over to you.
Thank you, Zach, and welcome everyone, and thanks for attending. So first off, just want to do a disclosure that I do serve on the Speakers Bureau for Cepheid. Next, just want to go over, I do have 23 years of nursing experience, with 13 years of that in infection prevention. Past president of APIC Chapter 46 in Arkansas, and I've been married to my high school sweetheart for the past 23 years. I have 2 children who are my everything. I have a daughter, Kelly, and my son, Zachary, who are both in college and are doing well. I have 2 rotten nephews that we adopted a few years ago. They are Caleb and Eli, and they are absolutely just one of the best blessings we ever received. Then we have our favorite child, who is Brutus Lee, and that would be our lovely boxer. Family is my everything, and these are some of my cousins and our children, and we do a family vacation every year, and we enjoy all of our time together. And last but not least, anytime I'm not worrying about infection prevention, I usually have a camera in my hand and love taking photos of anyone that will allow me. So now to get on to what you all are here for, and that is to talk about Clostridium difficile. So I am not a very patient person. I actually hate waiting whenever I want something. I obviously was a spoiled child, and from that I was usually given what I wanted. And so I think that patients should not have to wait as well, and that is one of the beauties of having on-demand testing. We can get results fast so that they are not having to wait for answers. So some background. CMS requires that all positive C. diff tests be reported into the NHSN, or National Healthcare Safety Network. And this is a value-based measure where you can see this on public reporting sites. Any positive C. diff that's collected on day 4 or greater after admission, you have to report as a hospital onset infection. So when we really started digging into our data to see what was going on in our facility, we identified that 30% of our patients that we had to report as hospital onset were actually symptomatic during their first 3 days of admission, and we feel was incorrectly categorized as a hospital onset, but because of reporting rules, we have to report those as hospital onset. So we began to work on what can we do to help work on this to reduce our numbers. This slide here represents, you can see when we put on-demand testing in place. And, our numbers looked pretty good, and then we went to on-demand testing, and the numbers jumped up there a little bit. And, a lot of this was based on our physician practices not knowing how to order tests, not knowing when they should order tests. And so, this has helped to drive our education to them. It took a little while to get there, but we are on the right track. So from reviewing the medical records, when we identified that 30% of the patients had symptoms on days 1 through 3, we felt like that this was probably one of our biggest bangs for our bucks to start working on those patients. So, and then the patients that were after days 1 through 3, we identified that those patients likely had either not had a bowel movement during their initial part of the first 3 days, or they had not had one documented. So they started stool softeners and giving them laxatives, and then we started getting results from those medications, and then the patients would start having loose stools, and we would test without stopping those medications. So you can see where we started with our SIR rates, and 2013, 2014 were essentially the same, a little bit up in 15, but in 2016 our work is really starting to show. So this is the prevalence rate of C. diff in our community. And you can see starting in 2012, we had a spike of the number of patients coming in from the community with C. diff. And, this spike could be associated with poor antibiotic stewardship in the community. And so when we saw these numbers, we decided to start working with our community providers. And through our Antimicrobial Stewardship Committee, we started publishing monthly rates of antibiotic utilization in the clinics. And we rank our physicians and mid-levels by their practices and show what their actual rates of utilization is for the number of appointments that they have. In some of our providers, we were seeing that more than 90% of the time patients were getting antibiotics. And so, right there tells us where we could start working in the community to try to help reduce these rates. So we, on a monthly basis, have a few clinics a month and go out and work with education, giving them information about when they should prescribe antibiotics and, appropriate treatments to try to help drive this prevalence down. And we are starting to see some decrease. It's not huge decreases, but we're in the right direction. So from all of our C. diff specimens that are tested, in December 2014, 21% of the C. diff specimens were positive. And then 2015, we're at 18%, and then 2016, we came down to 15.9%. So of the positive C. diff test in 2015, 31.38% was considered the epidemic strain. And then, so in 2016, it was down to 20.87. So we did some education with our physicians on appropriate treatments, and we put some wording on the actual lab reviews that was on this slide. So that it tells the physicians, the recent studies show that the epidemic strain may not respond well to the treatment with just Flagyl, and that more severe strains should be treated with vancomycin over the Flagyl. And so this is put on every one of the results that come out that are positive so that the physicians can determine treatment from that. So some potential issues that you may run into regardless of the type of testing that you do is inappropriate testing, retesting patients to see if they still are positive or if they are no longer positive. Testing times 3, we've seen that with some of our older physicians. That was a practice they were used to. Testing patients while they're on a laxative. Patients with a recent history, retesting those patients. Nurses have a bad habit of wanting to clear patients from isolation, and if they've ever had a history, they would order C. diff testing to clear them. And then one of our other big issues that we ran into was orders not expiring. So patients would come in and have some symptoms or belly pain, and the physicians would order C. diff testing, but the patients would not have a bowel movement or a loose stool until after day 4, and then we would test on the first loose stool, regardless whether it was 3 or more loose stools. So that was some of our education opportunities that we had with our staff. So we decided to work on a C. diff protocol in our facility, and in July of 2016, we implemented our first draft of this C. diff protocol, and we made that a part of our electronic health record. And then in November 2016, we decided to make some changes to this protocol and make it a little bit more stringent and require some more documentation to order C. diff testing. And then part of that protocol was an admission screening process that was built within our Epic system that would identify the patients that we felt that were high risk for C. difficile. So the high-risk patients that we identified were patients that are transferred from another acute care facility, if they were coming from a prison, a residential care facility, or a SNF unit. If the patients had been hospitalized in a hospital or the LTAC hospital within the past 90 days, if the patient had a history of C. diff, if there was any use of antibiotics within the past 90 days, and those patients we could pick up just from our charts, talking to our physicians in the community, and then if a patient had 3 or more loose stools, that was documented. So in order to get prepared to roll out the C. diff protocols and the BPAs, we had to assign our nursing leaders with coworkers, and we did some PowerPoint education that was required that our nurses had to watch. And for infection prevention, I needed to know, the processes that was going on and the workflows, and I was a support to all the leaders and nurses. And then daily I went out and I would round just to see if there was any issues after the BPA was turned on, and if there was any work that we needed to do, then we worked on that. For the protocol that we had to take to our medical staff for approval, it was just lined out, what the nurses would be ordering, what lab orders they were with the specific numbers so that they were aware of what protocols would be in place and so that they could sign off on that. Also, as part of education to our physicians and the rollout, we took this to all of our medical staff meetings, and then we also sent physician letters to all of our physicians on staff just to make them aware about C. diff and the protocols that were coming and what we wanted to do. So for our C. diff protocol, days 1 through 3 of the hospitalization was whenever the nursing orders, we wanted them to apply these orders. And the patients that were symptomatic, and this is just part of the actual protocol that was lined out that our physicians approved. We made some short phrases or smart phrases in the record so that it made documentation somewhat easier whenever they were ordering the protocol, so that they weren't having to search and look for the actual protocol itself. So for part of the quality metrics that we wanted to make it a little bit easier for our staff, when the patients were identified as being the high risk that I showed you on the slide earlier, that whenever our electronic health record identifies these patients, it automatically changes this bar across the middle of the banner to a brown color, and it will say C. diff protocol, just as another step to alert our staff that this patient is a high-risk patient and that you need to implement the protocol. After that banner is applied to the screen, the nurses then receive, it's called a best practice alert that will, it fires onto their screen whenever they're doing their admission process. And it is asking the nurse to order and collect the stool for C. diff testing, and this fires for them on the days when they're initially admitted. And if the nurse chooses not to order it at that time, or if the patient is not symptomatic, then they have to acknowledge and then document why that they are not ordering that test. After day 1, if the patient has diarrhea on days 1 through 3, if they have 3 or more loose stools, the nurse will then get this alert that will alert them to ordering the contact precautions, and it will also order the, to ask them to order the C. diff testing. That way that we can catch those patients early in their admission and not on day 4 or after, when we then have to report that as a hospital-acquired infection. If we get to day 4 and we've need a patient that would need to have C. diff testing order, we added, this is the next step that we added in November, was requiring our physicians to then document why that they would need to order this test, so that it prompts them to look to see, is that patient on a laxative or stool softener? Are they being treated with anything? And then, is diarrhea the only symptom that's suggestive of possible C. diff, or do they have other symptoms? And so the physician then has to answer these questions. That is an automatic stop before they can move through. So then they get the next screen whenever they get ready to sign the order. If they just bypass and still want to order Clostridium difficile testing, then they are then required to acknowledge that this test does not meet the acceptable testing criteria, and it's not recommended for the order, and then they have to acknowledge and put a comment in as to why that they still want to move forward with ordering that test. So for patients that had a C. diff order and has not been collected within the 48-hour time frame, the nurse will get an alert to tell them to discontinue that order. We also have put in a second step in case that the nurse misses this, for microbiology to automatically discontinue those orders in the microbiology department, so that we don't get a specimen that was not warranted. So for another step that we did was working with our staff on the appropriateness of stool specimens. So our lab first was who we worked with, because we were getting specimens that they were testing that really didn't meet the definitions. So they now only test unformed stool. We do not allow repeat testing. If the patient had a negative test initially, so for 7 days following that, we are not retesting. And then after initial positive test, we do not test again for 14 days. We've done a lot of work with our physician groups, asking them to not test for cure, that they should, based on the patient's symptoms, and if they've completed treatment, is when that they should consider the patient cured and not keep retesting. We've worked to expedite our processes of getting the lab specimens to the lab department immediately, so that they're not sitting and waiting. And then urine mixed with liquid or unformed stool is accepted into our department. So this is where some data to show you that we do believe that the electronic health record process is working. In January through June, our SIR rates for our C. diff here was 0.78. So we implemented our first round of protocols in July, and we did see a slight decrease, but not exactly where we wanted it to be. So that's when we started working on trying to get additional protocols and things put in place. So once we put that next step in that required our physicians to document on days 4 or after, then we saw the big decrease in our rates. And we are now a 0.43 SIR rate. And, we are very proud of our rates that we have been able to accomplish this. So I want to talk about one other benefit that we have seen with on-demand testing here at our organization is doing PCR blood testing for all gram-positive cocci in blood cultures. We really wanted to make sure that we were saving our antibiotics when we truly needed them. and we wanted to treat the patients appropriately and quickly. So by having this has helped to get this done. From a recommendation from our Antimicrobial Stewardship Committee, we implemented the PCR testing on the gram-positive cocci. And then on the results, we actually have included wording that for patients that have a possible skin contaminant, to let them know that this is a possible skin contaminant and that the patient may not have an infection, and so therefore they may not need treatment. We educated our providers on the new testing and the accuracy of the testing. We went to every medical staff meeting that we could just to make sure that they were aware of what we have implemented so that there would be no questions about it. So after we implemented this PCR testing, we reduced our average days of antibiotic therapy by 5.775 days. And this is per patient. We also reduced the number of antibiotics that our patients were getting by nearly 1 antibiotic, and then their length of stay for these patients was decreased by 1.433 days. So, this was huge for a huge win for our antimicrobial stewardship team to see that we are getting patients now treated appropriately and getting them out of the hospital quicker, and they're not getting all the antibiotics that puts them then at risk for having C. diff. So this slide is a telltale sign that we still have some major issues with our blood culture contamination. When you see that the coag-neg staph rates are, pretty high and continue to go up. And so, there is a lot of work that we need to do with our contamination rates, but yet knowing that we still have the coag-neg staph, those other patients are getting treated appropriately, and we are reducing that risk of, prescribing them antibiotics that's not warranted. And so therefore they get appropriate treatment and get in and out of the hospital faster. So this concludes the presentation, and we'll open for questions now.
Well, thank you very much, Trish. We do have a few minutes to take some questions, and it looks like we do have some in the queue. As a reminder, if you have a question, you can click on the Q&A widget at the bottom of your screen. If we don't get to your question today, Trish has generously offered to work with us to respond to additional questions via email after the webcast. Our first question is as follows. Could you clarify what you mean by implementing on-demand testing? I guess, in other words, how quickly is the lab turning around results?
We are getting, as soon as they get the specimen, they are trying to run that specimen right then. Usually the average time that the staff have to wait is around an hour and a half to less than 2 hours is the average report out time.
Okay, great. And the next question is, how long do you keep a patient on isolation when C. diff is positive?
We keep our patients on isolation until they have completed treatment and been off of treatment for 48 hours with no symptoms of C. diff. Once they have completed that time frame, then we move that patient to a new room and have that room cleaned, and then we will take them off of isolation.
Great. And the next question is, has your institution done anything differently to better address CMS reporting requirements?
I'm trying to think. As far as reporting, we have an electronic health software that helps with reporting our infections. But knowing that our rates were above where we wanted them to be at, that's when we started working to improve our rates and really digging into our charts to see, are we doing appropriate testing? Are we testing patients that were on stool softeners? Just trying to work to reduce that. And, we knew we had some issues and implementing the on-demand testing, there was such a huge spike, and we had some pushback from some folks not wanting to use the on-demand because they felt like we were reporting too high rates. But, once you can see that when we started getting more appropriate testing, our rates are down below what they need to be for value-based purchasing. We're 0.4, which is significantly lower than the benchmark.
Okay, and the next question, are there any situations where providers are allowed to order repeat C. diff testing within the 7 or 14-day block, or is this a hard block across the board?
If they order that, then they have to document a reason behind why they are ordering that. They can get around it, but they have to document why.
And a follow-up along those lines, have you had much pushback from your physicians on the testing criteria you've implemented? Have there been those who didn't receive it as well as others, or hurdles in that implementation?
We had one physician that actually called that was a little bit upset after we talked about it. He was fine. Most of our other providers actually wanted more stringent guidelines. They wanted patients to have, they didn't want us to do a 48-hour cancellation on the order. They felt like if the patient was not having loose stools in under 24 hours, that's when they would DC that order. But we kept it at 48 just to, until everyone got used to that. But most of our providers actually wanted more stringent than what we actually went with.
And I think maybe time for one more question. Do you isolate patients with a history of C. diff on readmission, even if they're not symptomatic?
No, we don't. And if the patient comes in and they've had a recent C. diff positive test and they are actually on treatment, we will put those patients in isolation. But if they are not on treatment and they're not symptomatic, we then go into our health record and resolve that infection and so that they are not placed in isolation. Okay,
great. Thank you, Trish. Well, we will leave it there, and if we didn't get to your question, we will try to respond via email in the next few days. As a reminder, a replay of this webcast will be made available later this week, and please do keep an eye out for email invitations for the next 2 webinars in this series in February and March. I'd like to again thank our speaker, Trish Gould, for her excellent presentation and for answering the questions, and thank everyone who took the time to join us today. We hope you enjoyed. Have a great rest of your day.